Hello. Hello.
Hi, good
Hi,
afternoon.
sister.
Yes, good afternoon. How are you?
Please, we are fine. Yourself?
I'm okay. Okay, so now let's go through the nursing care delivery models or systems. So these are some of the frameworks that we use in the ward to take care of the patient. So in this lecture, we will have to explore the various nursing care delivery models used in healthcare settings. Some hospitals here in Ghana are using these frameworks. So these models are designed to ensure that patients receive the best possible care in a structured, effective, and efficient manner. So after we've done the ward management, and we need to also use this framework as part of ward management. Okay, so understanding these models is essential for future nurses, midwives, as they prepare to work in a dynamic healthcare environment. So as you learn this one, when you go back, please apply them. It's not only for learning's sake. You are here to learn and apply it to your practice. Okay, so in the end, we define nursing care delivery models, the purpose and importance of the NCDs, principles of personal assignments. We describe key nursing care delivery models, then some of the characteristics of the assignments, discuss it. So with the assignment, we take it and discuss the both advantages and disadvantages. Then we also need to identify the factors influencing the choice of a particular model. Hello.
No, please, we can't
Hi,
see.
doctor, please. Your screen is not showing.
Okay. Can you see now? Hello.
Yes, madam.
Yes,
Yes,
ma'am.
please.
Yes, madam.
Okay. So as I was saying, yeah, this is the course objectives. So one of the important function of the professional nurse, as we did in ward management, this is also part the framework that we can use to assign patients for nurses. So at the first line management position of nursing service department is organizing. Organizing the activities of the staff into workable pattern to meet patients' needs. So this is also part of organizing. As we have done the ward management, you have to put structures in place so that work assignments would go on. As a nurse, you should establish effective relationship between the activities to be performed, the workers to perform them. So who are the workers? What are the activities? Now that even we have a lot of people, a lot of nurses, especially student nurses, we need to also don't let them stay on the ward without doing anything. not only running errors, no. So running errands will not help them. At least you need to assign them, use this nursing care delivery, the models to assign them to the task. Okay, so what is it? It refers to what? A systematic process through which nurses and other healthcare professionals provide patient care. That is the nursing care delivery models. It's also called what? So, nursing care delivery, we deliver care. So nursing care delivery, it refers to a systematic process through which nurses and other healthcare professionals provide care. But what about the system? Nursing care delivery models, what is it? It can be called care delivery system or patient care delivery methods. And this one, it details the way task assignments, responsibility, and authority are structured to accomplish patient care. It can also be said as well, it's a written delegation of duties to care for a group of patients by trained personnel assigned to the units based on their skills, your job description, and patient nursing needs. Okay, so what are the purpose of the nursing care delivery models? Okay, so one of the purpose is to delegate the work to be done to the nursing personnel employed in the units based on the administrative policies, line of authority, we have done organizational structure and job description. So we've done that last semester to gain the cooperation of the nursing personnel by what? Knowing and accepting the acceptance of the work to be done, define responsibilities of each staff member, provides for teaching of staff nurses and nursing students. It prevents overlapping of what? Nursing functions. Okay, so this is the criteria for selecting the appropriate. So how do you know this model or this framework will suit a particular ward or a particular unit? So you need to consider the skills and expertise of the staff before you choose a particular model. The availability of registered professional nurses, the economic resources of the organization, the acuity of the patient, yes, then the complexity of the task to be done. So before you select a particular model to be used in your units, you need to consider this. You need to consider this criteria before you be able to use a particular model. And these are the principles. It's made by the first line manager who is supposed to use the framework. In charge can use it. So it's made by the first line manager, that is the head nurse or nurse in charge for each individual. It is based on nursing needs of each, as I said, your job description, your skills level, your experiences, and all those things. So it is planned from week to week rather than from day to day to assure continuity of care. It takes into account all direct, indirect, and unit activities there. It's considered the geographic location, the unit, and the assigned duties to save time and effort. It must be balanced among nurse and staff. Never to assign the same task to more than one nurse. So these are the characteristics of effective assignments. If you want the assignment to be effective, it should be done according to the personnel abilities, yes. and their patient needs. It should be written clearly, concisely, and legibly. Should be posted in a place easily accessible. Should be related to previous assignments in order to provide for progressive learning experience on a weekly basis and adjust daily to meet changing patients' needs or changes in nursing personnel. It must be timed. So these are the methods that I've been talking about. So we have this method of the nursing care delivery models or system. This is a framework. So we have several methods of assignments are used to plan for the patient's care in a hospital. So we can group them under traditional method and advanced one. Traditional method and advanced method. So these are the traditional method and the advanced method. We have the total patient care. That is a case method. Functional method. Team nursing, primary nursing, modular nursing. Then the advanced method, we have case management. We have practice partnership, differentiated practice, and patient-centered care. So basically, these are the types of care delivery that we have. But as I said, it depends on them. So when you want to use a particular type of these models, you also need to know the criteria, the characteristics, the principles, and everything before you go ahead and use a particular model. So let's see that. Let's go through the traditional models. We have the total patient care, that is the case method. So this is a traditional model where one nurse, the case method, or you can have it or a total patient care, is responsible for the total care of what a patient during a shift. So that is why I had a case. It's not a case. So the nurse performs all the tasks for the patient, from assessments to administering medications and providing emotional support. So that is why I had the total patient care. As you can see, it is 10 days. We have the nurses there. They provide what's medical care, emotional support, pain management, education, patient satisfaction, prevention and wellness, care coordination. As I said, it is team-based care. Total patient care. Example, a post-operative patient recovering from a major surgery. We take care of all the aspects, medication, all the tasks for the patient. So then the same nurse assesses vital signs, administers medication, provides wound care, and educates the patient about post-operative care. So that is total patient care. So I said one nurse. So that is why I said you have to also use the criteria before you use a particular model. If you can say one nurse is not available, you can't use this particular model. So one nurse to one patient. So this is what a traditional model where one nurse is responsible for the total everything. You do everything for the patient. So these are the key features of the total patient care. One nurse, you have full responsibility. So a single nurse is responsible for all aspects of care leading to better communication and trust. There's also high autonomy for nurses. Then there's clear lines of authority. Each nurse is fully responsible for their assigned patient, reducing confusion. So if something happens to the patient, you will be accountable for the patient. There's better nurse-patient relationship because nurses, the patient see fewer nurses. So the nurse and the patient. There's effective handover. Communication between shifts is easier because fewer nurses are involved in patient care. So this model is commonly used in critical care setting, ICUs, and private duty nurses where individualized attention is crucial. So these are the key features. Example is this. So let's say Sarah is a registered nurse in an intensive care unit, starts her 12-hour shift, and is assigned to care for 2 critically ill patients. So let's say a single person caring for what, one person and one patient. So this model, this holistic care, Sarah is responsible for all aspects of care for her assigned patients, including medical, everything. We have done that. This personalized attention. Since she has only 2 patients, she can spend more time addressing their needs and concerns, building a strong nurse-patient relationship. There's direct communication. So during shift change, Sarah provides what? A detailed handover to the nurse, ensuring smooth continuity of care. Then there's quick decision making. If patient's condition deteriorates, Sarah can make timely intervention without needing to delegate tasks. So these are advantages. It is holistic and continuous care, better communication, stronger nurse-patient relationship. There's high accountability, quick response to patient needs, and there's easier shift handover. But the disadvantage is it requires strong leadership coordination. Yes. If you are not a strong leader, you cannot do it by yourself. Can lead to confusion if rules are not clearly defined. It needs large number of staff nurse. Yes, before you use the total picture, because you want nurse to one patient. So if Sarah has a nurse giving 2 patients, you cannot give more than 2 patients or whatever. So another nurse will also you're able to use any of this model. You need to also use the criteria that I discussed before you do. So this model is commonly used, as I said, in critical care setting, ICUs, and with private duty home nurses, where individualized attention is care. And it enhances patient-nurse relationship, yes, continuity of care and accountability, but it may be challenging in settings with staffing shortage. Obviously, cannot do it. Then the functional nursing care, functional model. So with this model, the work is divided into tasks, unlike the team total case method that we have a case that you're supposed to take care. But this one, the work is divided into tasks, with each nurse or healthcare worker assigned specific duties. Yes. So for example, one nurse might be responsible for giving medications while another nurse handles documentation. So that is how this one works. So individual is given a task where he's comfortable with or where he's skillful. So this one is called task assignments. There's division of labor, there's efficiency, there's specialization, there's also teamwork and coordination, standardization, and task. Outbreak in Ghana, functional nursing was used to manage the high patient volume. It improved efficiency, but patients felt a lack of personalized care because someone would take medication. You see a lot of nurses taking care of you. So let's see the key features, as I said, is task-oriented approach. Nursing care is divided into specific tasks, and each team member is assigned a particular role rather than a group of patients. There's hierarchy of roles. The registered nurse supervises and coordinates patient care. The licensed practice nurse, here we don't have the license, so we can have maybe the positions, the seniority. So we all have principal nurse, PNO, SNO, and all those people. So we can also give them a task. So the most senior nurse coordinates the patient care. Then the other nurses And this one, there's efficiency and speed. The model allows for rapid task completion because everybody has his or her own task to perform, making it useful in high patient load settings like hospital and long-term care facilities. There's clear division of labor. Responsibilities are assigned based on staff, your qualification. As I said, we have seniority here, PNO, we have a degree nurse, the BS, and all the diploma nurses, the staff nurses. Here, we don't have the licensed practical nurses. We have that kind of position here in Ghana. And yeah, expect this. It is cost effective, minimal nurse-patient relationship. Yes. There's best for high volume settings. So commonly used in emergency rooms, long-term care facilities, and surgical units where efficiency is critical. So while this model maximizes efficiency, it may also reduce continuity of care and patient satisfaction due to limited nurse-patient interaction. We have a whole lot of nurses performing their tasks. So efficient, especially in high demand setting like emergency, focus on specific tasks, allow for specialization. There's less equipment and supplies are needed. Tasks are completed quickly because everybody is taking part of something or doing something. But there is limited patient-nurse relationship. That would be a challenge. There's fragmentation of care. Yes, this person is doing this, another is doing this. So there's fragmentation, which may lead to oversights. Then function-centered method, then it is difficult to define responsibility of errors in patient care. So this example, where large physical ward in a hospital adopts the functional nursing model to handle a high number of post-operative patients efficiently. So we can apply this model, division of tasks among staff nurses. So we had the head nurse, oversees patient care and manages. So the head care manages the team. Then we have one senior registered nurse is responsible for administering IV medication injections. We can also have 2 staff nurses, handle wound dressing, monitoring vital signs and all those, and 3 nurse assistant assist with supervisor gathers updates from all the staff and provides structured reports to the incoming team. So that is this. The outcome in the end, there's high efficiency. There's clear assignments, limited nurse-patient relationship, and what best suited for large hospitals, emergency units, and long-term care facilities, where speed and task specializations are crucial. With the team method, that is for democratic team leader. So we have a team leader here. So we are a team of nurses or staff coming together to provide care for a group of patients. So a team of nurses led by a charge nurse or a team leader. That is called team nursing. They work together. So this model is typically seen in the larger hospitals units, and each team member performs a specific role, but the team collaborates to meet all patient needs. So that is team nursing. So there's delegation here. There's efficient care. There's skillsmiths. Everybody will bring on board our skills as a team. So there's a collaborative nursing care. So as I said, there's a team leader nurse. So let's say regional hospital in Kumasi adopted team nursing in its medical wards. Nurses reported improved collaboration, but some found it challenging when teams lack clear what delegation. Let's go to this here. So these are the key features. A group of nurses and support staff work together to care for a set of what patients. Then the team leader oversight. So we have a registered nurse. It serves as the team leader. So we have a team, let's say by maybe 5 or 6 teams members in a team. Then we share our tasks, but there's a team leader here. So delegation of tasks, the team leader assign duties based on each member's skills, needs, and qualification. Then we have the other staff members handle treatment, medication, administration, and documentation. The nurse assistant assists with basic patient care like bathing and what feeding. So that is what. There is efficient use of staff, there's continuity and collaboration, there's improved patient outcomes, and there's flexible and scalable. Can be adopted for various healthcare settings, including hospital, meal wards, nursing homes, and rehabilitation centers. And this is an example of the team nursing model in practice. So let's say a busy medical surgical ward in a hospital uses the team model to ensure efficient patient care. So how do we apply this model in the med-surg unit? So we can form a team. So formation of the care team, a team of 1 registered nurse, 2 licensed nurse. So here we don't have the LPNs, we have the other position, seniority position. So with the registered nurse, then we have the position, the higher position. So now we have PNO, BDNS, SNO, NO, then the staff nurse. So we can have this team together. Then we also add the nurse assistant. And so who is supposed to do the delegation of tasks? The team leader oversees patient care, makes clinical decisions, administers complex medication, and updates care plans. Then the other staff, but they are all registered nurses. They perform tasks such as vital signs, monitoring wound, and routine medication administration. Then the nurse assistant assists with activities of daily living, such as bathing, feeding, position, or whatever patient. So there is what collaboration and communication. So in the end, the team leader holds a short briefing at the start. So when you want to start this model, once we have a senior nurse who is a team leader, who have a short briefing at the start of the shift to discuss patient conditions and assign duties to each of the team member, what they're supposed to do. So throughout the shifts, the team members report updates to the team leader, ensuring coordinated care. Then there's efficient care delivery. Patients receive timely intervention because responsibilities are well distributed with the team. So if you know that we have in the during the shift handover, at the end of the shift, the team meets to update the next. So you have started a meeting, you had a meeting as to how to go about patient care. Then when the shift is over too, you have to also update the next team on the patient progress and any changes in care plan. So every shift there is a team. Every shift there is a team. So what will be the outcome? Patients receive what? Comprehensive, well-organized care, while nurses work efficiently as a team. Staff avoid burnouts by sharing responsibility based on your expertise. You are good in IV, you are good in medication, you are good in wound dressing, getting the IV line. So we share it according to our our expertise. So there's a skill mix. Continuity of care is maintained, leading towards better outcomes and satisfaction. So this model can be used in hospitals, as I said, medical surgical ward. We can also use as nursing homes and rehabilitation centers, where team coordination and delegation are essential for managing multiple patients. So these are some of the advantages and disadvantages of team nursing. So there's availability of professional nurses skills. Yes, there's a skills mix for a larger number of patients. Continuity, so continuous supervision of less trained personnel, yes. That's providing better patient care, increase in number and duration of professional nurse-patient interaction. It's help in developing leadership skills, yes, as a team leader. So you have to get the leadership skills. So whoever is a team leader need to apply the skills mix. Then disadvantage, most nursing programs do not prepare nurses for leadership roles. So if you say you are the leader and you are not efficient, effective leader, the work will not go on well. So nurses are more interested in developing clinical patient care skills than leadership abilities. So now you need to also have this, developing that kind of leadership ability. With staff shortage, it's difficult to properly apply this method because we are doing in team. And even if in the morning we have only about 3 nurses, how do we form a team? So a team should be at least 4 to 6 members. So if you have only 2, sometimes even there is only 1 nurse, one staff in there before you can use this model. So these are the disadvantages and advantages of team nursing. Modular nursing. So what is modular? So team leader nurse, that is modular nursing. Modular nursing is a modified team nursing. So it's a modified team approach where a unit is divided into what? A manageable what? Component called a modules. So where we have but sometimes it depends on the geographic location. And each team is responsible for what? A specific patient group. So as I said, it's a modification of team nursing, where a unit is what? Divided into a manageable what? Components called modules. And each team is what? Responsible for what? A specific group of people. Here, the idea is to organize patient care into models that can be effectively assigned to nurses based on their expertise and the patient's needs. So the models may include such as source. We have a model here as a medication administration, wound care model, patient education units there. So models. So as I say, we have a team leader. Medication model, so medication administration. So it's like a team, but this one is a modified team approach. So there's vital signs what models in the units in the geographic area. So you need to also monitor vital signs. There's a team leader there. There is treatment model and education model where you patient teaching and support are done there. So that is team nursing. So these are the key features of the model. There's team-based care. So the nursing staff is divided into small teams. That is why we call it modules. Each responsible for a group of patients with a specific units in there. So geographic assignment, each model works in a designated area. So we have my own area here, geographical assignment here, my team are here, the vital science team are here, education team are here in the model. So each model works in a designated area, reducing travel time for nurses and improving efficiency. So the team leader supervision, a team leader is usually a senior nurse a registered nurse. Oversees the model, ensuring proper delegation and what's coordinating of tasks. There is also collaboration among staff. The team includes registered nurses and nursing assistants who work together to provide holistic patient care. So there's continuity and personalization. Since the same model cares for the same patient during the shift, the nurse develop familiarity with patients, improving communication and allowing tasks to be completed more effectively. There's balance between total and team nursing. So this one, it combines an element of what? Total patient care, as described earlier, and team nursing also, ensuring what? Both personalized attention and shared responsibility. And can be used in medical surgical units, general hospital wards, and long-term care facilities to improve patient outcomes and nursing workflows. So we can apply this model as a scenario. A medical surgical unit in a hospital implements the modular nursing model to improve patient care efficiency and teamwork. So how do we form these models? The unit is divided into two models, each covering a specific section of what? The wards. So each model consists of one, as I said, the one senior nurse, senior registered nurse as the team leader. Then we also have the one assistant nurse. So geographic assignment, the module A. So as I said, we have two teams, two models. So model A is assigned patients in room 1 to 10. Yes, so we create that model. So then while module B handles room 11 to 20, if you have that one, we have labeled it as that. So we divide them into two models. So geographic area, each have their own units or their models. So if you have a hospital we can divide them into two. And every A have his own team and B also have his own team. Then they work together. So model is assigned, model A is assigned patient in what? So you will not go to room 1 to 10 because room 1 to 10, we have a model there. Then room B also handles what? Room 11 to 20. So that is the modular thing that I'm talking about. And I think I think here in University Hospital, in some time, we use this type of what models. So when you go to your hospital, the team leader will meet you. So you take room, you assign room, this, then you create the models and the units for you. So this setup reduces nurse working distance because we have to come and take this, to come and this, but everything is in the units, the model, the geographic area where you can have them and take care of the patient. So let's say a medical surgical unit in a hospital implements the modular nursing model to improve patient care efficiency and what teamwork. How do you apply? So the unit, as I said, is divided into two. We have done that. So there's collaboration and task delegation. The RN coordinates, let's say the senior nurse coordinates administered medication and updates care plans. The other staff nurses perform routine treatments and assist with assessment. Then the nurse assistant helps with activity support, daily living. Then there's a continuity of care. Patients receive consistent care from the same model members, improving trust and communication. So during shift handovers are more efficient as the model team updates. Yes. incoming nurses about patient progress. There's improved efficiency and patient outcome. So the teamwork and focus assignments ensure that all patients receive timely care. Nurses feel less overwhelmed as responsibilities are well distributed based on your expertise. So patients experience better satisfaction as they interact with familiar caregivers throughout their stay in the hospital. We can apply it, or we can use this model in the medical surgical units. We can also use it at rehabilitation centers and long-term care facilities where efficient team coordination is essential for patient care. So this team, the modular nursing is also good. So these are advantages and disadvantages of modular nursing. It decreases the sense of isolation and unrealistic expectations. It increases continuity and quality of care. More time may be spent in direct care. Nurses' morale is improved. With the disadvantage, increased cost to stock each model. Because as I said, you don't have to work. We have a geographical area, maybe 1 to 10. We have your model there. We have all the things that you will need or you require for patient care. So you don't have to come back and walk to the nursing station or whatever and take any equipment. But this one also need re-establishment or redesigning of the ward, so that we can have all our things in a room, so that we cannot walk at to the nursing station or hide to take or to pick some equipment. So as I said, it increases cost to special care nursing hospital. Everybody has his room. It's not a corridor. We have room 1, room 2, room 3, room 4. So if you apply this model, it can work effectively. But how to get the resources to do it? So that is about modular nursing. Then what about primary nursing? Primary nursing. In this model, one nurse is responsible for managing the care of patients from admission to discharge. Listen, one nurse. So the primary, that is why we have the primary. The primary nurse coordinates care with other team members, but the primary nurse remains the patient's main contact. We have a team, but I am the primary nurse. I have to take care of you. So the primary nurse is responsible for the patient 24/7. So 24 hours a day for total patient care from admission throughout the discharge. So what happens if the primary nurse is not there? What do we do? If the primary nurse, because he is responsible for the patient 24/7. So if he is not there, because obviously we have to go close for our shift. So when I am close for my shift, who will take charge of me, of the patient? Because I am supposed to take care of the patient 24/7. This is what we will do when the primary nurse is not on duty. There's associated nurse. So the associate nurse who follow the plan by the primary nurse. So the care plan established by the primary nurse provide care. But when he or she comes, she would hand over everything and inform the primary nurse what happened in his or her absence. So that is the primary nurse. So what happens? The key feature is holistic and unfragmented care. One nurse is responsible for the patient's care during their shifts, ensuring consistency. There's fewer caregivers. The patient interacts with a limited number of nurses, leading to better knowledge of their condition and needs. There's improved communication and collaboration as shift changes involve direct communication between nurses. It enhances patient continuity of care. There's high autonomy for nurses. The primary nurse make in their role, reducing confusion and patient management. So it enhances nurse-patient relationship, continuity of care, and accountability, but it may be challenging in settings with staffing shortage. So we have a scenario here. A hospital introduced the primary nursing model in its oncology ward to improve patient outcomes and satisfaction. How do you apply this model? You assign a primary nurse. So let's say we have nurse Ajman, who is a 50-year-old cancer patient. So we have this is a patient. So Miss Ajman, who is a 50-year-old cancer patient, is assigned to what? Nurse Linda as her primary nurse. So Nurse Linda is responsible for developing and overseeing Mrs. Ajman's care plan throughout her hospital stay. Yes, Nurse Linda. So there's a patient, Miss Ajman, who is has a cancer in the oncology department. So we have one primary nurse who is only responsible for care for Miss Ajman. So during each shift, an associate nurse assists in providing care while following nurse Linda's establish the plan. You will plan for everything about the patient. But once you are not there, you hand over your plan to the associate nurse. So when you come back, the associate nurse also inform you or tell you about what goes on. So Nurse Linda checks in daily to evaluate the programs, progress, adjust treatment as needed, and ensure consistency in care. So here there is personalized and holistic care. In there to frustrate the patient, because the primary nurse should be empathetic, so a therapeutic nurse, not any other nurse who should be aggressive and all those things. No. So there's effective communication and coordination. So as shifts change, Nurse Linda and the associate nurse discuss their patients' updates to ensure seamless care. So Nurse Linda collaborates with doctors, physical therapists, and dietitians. So everything about the patient to create a comprehensive care plans. So this time there's improved patient outcomes. These are the reports feeling more comfortable and supported because of the consistent care from Nurse Linda. So this personalized approach helps her adhere to her medication and lifestyle adjustments. So it can, as I said, it can be applied to in-home health nursing, oncology, palliative care, and long-term care settings where continuity and strong nurse-patient relationship are essential, very important here. And these are the advantages. It decreases the number of people in the chain of command. I've told you about the chain of command. You know the principle. Reduces the number of errors and cost per patient per day. There is mobile use of auxiliary, increase satisfaction of nurse and patient, and a patient is secure. But if the nurse is not empathetic and then you add stress to the patient's life. So it confines nurse talent to the limited number of patients. That is a disadvantage. It is time consuming. Its success depends on the quality of the nursing staff and administrative support. Then it requires, as I said, excellent communication between the primary nurse and associate nurse. Then the nurse may have not the experience or educational background to provide total patient care for them.
I'm a question.
The case method, team nursing, modular nursing, partnership, and all those things. Okay, so these are the more advanced ones. Practice partnership, the more advanced methods. So we have B, the traditional method, and the more advanced methods. So traditional, we have the case method, primary method, team method, modular, and the like. And with the advancedness, we have the practice partnership. What is it? And this model is a nursing model that emphasizes collaborative relationship between the nurse and the patient. That is practice partnership. We are partners in our care. So it's about the relationship between the nurses and why they form part with the patient. As you can see, there's mutual respect. So the nurse, it focuses on mutual respect. There's shared decision making. Yes. So mutual respect, building trusting relationship, and partnership in the delivery of care. So we are partners in the care. So in practice model, the nurse and the patient work together as equal partners. So we don't feel that we are boss over them. We are partners to achieve optimal healthcare. So we empower each other. There's mutual respect. That is where we build trust, with trusting relationship. Empowerment, we encourage patient involvement in whatever care that we render to them. There's shared decision making. So here there's collaboration, communication, and patient satisfaction here. That is the practice partnership. So we are partners in our care delivery. So with the characteristics of the partnership, there's empowerment of patients to take an active role in their healthcare, and nurses support the patient autonomy and involvement in decision making. If we build trust, there's a trusting relationship and a strong nurse-patient relationship. Example is in chronic diseases management like diabetes, hypertension. So a nurse working with a patient diagnosed with hypertension or diabetes might discuss lifestyle changes, then you also need to follow, we involve them. So please don't do this, don't do this, go by this. So medication and self-monitoring strategies. So we are partners. We are involved with each other. There's that kind of trust. And whatever I say, the decision, we share the decision. Only disease like hypertension and diabetes. We can also have in disease like palliative care. That is in end-of-life care, nurses practice partnership by discussing their patient preferences regarding their care, respecting their choices, and ensuring that the patient wishes are met while providing comfort and support. So that is the partnership. Then we have the practice, that is the co-primary. Then we have the case method. Case method. What is it? The case method in nursing is what? This also a collaborative. So we have a nurse case manager who have a comprehensive care of the patients. So the nurse manager is a collaborative process that involves what? You need to assess the patients like the nursing care plan, assessment, the nursing process, use the nursing planning, facilitating, and advocating for options and service to meet a patient health needs. So that is a case management. This one, you are plan, you coordinate care, you monitor, you advocate. So you start from the assessment, then towards the. So this one, it is a holistic approach that focuses on ensuring the patient receives a comprehensive care from the prevention. You start from the prevention. So when the patient needs disease prevention, you talk about disease prevention, but when the patient comes to the ward there's a treatment to follow up and rehabilitation. So prevention, then treatment, and what? Follow up when the person is discharged. There's also, you follow them up for a rehabilitation. So that this is comprehensive. That is case management. That is coordinating comprehensive patient care from the beginning to the end. Even when the patient is being discharged, you follow the patient up. So there's holistic assessment. You plan for the patient care. You also coordinate all the resources that the patient will need. It is your responsibility. Then you are also patient advocacy. So you also need to ensure that the patient do the follow-up care. And the rehabilitation as well, you follow the patient up. So the case management model emerged in a response to the complexity of what a third-party healthcare pays and rising healthcare costs. So this one, it is a dynamic and systematic collaborative approach to coordinating health services for what define the population. The management. So, as I said, implementation of services to achieve the desired outcomes within a specified period. So the case management. It primarily focuses on what administrative aspects rather than what direct healthcare. So we make sure that when you come to the hospital, whatever thing that you need, the case manager will make sure that it is there for you to achieve a desirable outcome. So if it needs resources, he has, as an administrator, he needs to provide that care. So it organizes care by major diagnosis or diagnosis-related groups. So to achieve predetermined patient outcome within a set time or frames and resources within that specified period, the case manager will know that you get all the things that you need for your care. So the goals of the case management: improve patient outcomes, ensure continuity of care. Yes, when you are discharged, we follow up then to rehabilitation. It reduces costs, enhances quality of life. So let's see the case manager role here. So the next case manager role, that is a professional qualification. You have need advanced practice, managerial and communication skills as your role. You don't just have any other person. Your qualification also matters. So it is recommended by the American Nurse, ANA. We have a minimum preparation degree in nursing and 3 years of clinical experience before you can be appointed as a case manager. So as a professional, we don't just get up and say you are a case manager. Your degree needs to have at least BSc, BSc degree, and at least 3 years of clinical experience before you can be appointed because it's like more of administrative work where you have to manage a case. The patient is there, but all the things that the patient needs, you make sure that the patient gets it. So responsibility in acute care. You manage a caseload of at least 10 to 15 patients as as a case manager, you need to manage about this. Then you follow patient from admission toward discharge. Then you also need to ensure continuity of care. So that is the case. You need to take this case, then administratively you manage the case. So these are the responsibility of the case managers. You need to assess patient and care plan, as I said, assessment to evaluation, care coordination and communication. You need what your responsibility is to provide emotional and psychological support. You also need to collaborate in the discharge planning. Then when there's a crisis intervention and problem solving, you are there with the patient. Quality improvement and policy development for this patient. Okay, so these are the components of case management. As I said, you assess, you plan, you implement, you monitor, advocate, and coordination. Then you evaluate, you review the effectiveness of the care plan, making was improving. So these are the components. As you saw from the definition, the case manager assess plans as you. And these are the advantages of the case management model. Enhances nurse professional development and job. Yes. Increase collaboration between different health professionals. Reduce patient complication. Improve quality of care. Facilitate the continuity of patient care. Facilitate discharge of patient care, then reduces costs. So the disadvantage is that it requires specialized training. So lack of proper training can impact clinical decision communication. Yes. High caseload, overwhelming caseload may lead to delays towards patient outcome because you have about 10 to 15 patients within a specified period. Implementation challenges. High responsibility and autonomy can make effective implementation difficult. Professional conflicts. Conflicts may arise with other professionals, social workers, because sometimes it is a social worker's job to when the patient needs something. But as a case manager, you also organize all those things for the patient. The role requires highly educated and skilled personnel, which can be expensive. So with the critical pathway, there's another one called critical pathway. So the critical pathway is only about the path that you use to care. So now we have the protocols, clinical practice guidelines, patient care protocols or care maps. So these are the predetermined plan of care for particular health problems. So that is the pathway. Which of the protocols are we going to use? That is what the critical pathways. So these are the tools or guidelines that direct care by identifying what expected outcomes that are developed by the collaborative practice. Guide care. So that is the critical pathway. So as I said, it includes specific medical diagnosis, the expected length of stay, patient identification, data appropriate time for frames. So that is about this. Let's go to the patient-centered care. Patient-centered care model. So this one, it focuses on the whole patient, the totality, comprehensive, holistic. So patient-centered care sometimes referred to as what focus care. It's a more recent development in nursing care delivery model, and it's as a result of what redesign of what work organization or units. So this model emphasizes treating the patient as a whole person, focus not just on their physical, but also on their emotional, social, psychological well-being. Even spiritual aspect is also part. So with the patient-centered care, it promotes collaboration between nurses, patients, families, and other healthcare. So as a holistic care, patient-centered care, you need to respect the patient. So you personalize care, addressing physical, emotional, and cultural needs. Patient engagement, encourage patients to practice in their care. There's also family involvement, including family in their care. So you need to respect individual preferences, empowering patients to make decisions, ensuring compassionate, holistic care. Then promoting family support and participating. So that is patient-centered care. That is holistic approach of care, holistic nursing. So these are the key principles of the patient-centered care model. So you need to respect for patient preferences and values, coordination and integration of care. Care is well organized across different healthcare settings, ensuring what smooth transitions between providers, specialists, and support services. Information, communication, and education, they are clear. So give clear and timely information is provided to patients. Relief and comfortable hospital environment contribute towards overall well-being. That is physical. There's also physical comfort there. There's emotional support and alleviation of fear. So in psychological treatment, involvement of family and friends, continuity and transition of care, then access to care. So patients receive timely medical attention, including appointments, scheduling, emergency care, and easy access towards patient service. So that is patient. So let's go through this scenario. And a 55-year-old male patient, Mr. Asante, is admitted to a hospital with uncontrolled diabetes and food ulcers. So the healthcare team adopts patient-centered care model to ensure his treatment aligns with his needs, preferences, and values. So how do we apply this model? Now we have Mr. Asante. So with holistic, we have holistic and individualized care plan for Mr. Asante. So the health team, including doctors, nurses, dietitians, and care specialists, meets with Mr. Asante to discuss his medical history, lifestyle, and personal preferences. His cultural beliefs are also discussed. So his cultural beliefs about food and treatment preferences are considered when developing his care plan. So we have a whole team of healthcare professionals who plan for Mr. Asante. So they said decision making. Mr. Asante is actively involved, yes, in choosing his treatment options. The doctor explained at home. There's also emphasis on communication education. The nurse also ensures Mr. Asante understands his condition, treatment plan, and wound care techniques before discharge. We can also have, as we do on the ward, printed educational materials are provided in his preferred language, and he is encouraged to ask questions. So that is patient-centered care model. It's very good. when you use it, it's very good. So there is what? Emotional and psychological support here. So this one, we have what? A hospital social worker assesses his emotional well-being, or psychologist, and discuss concerns about managing diabetes at home. A peer support group too is recommended, where he can connect with other diabetes patients who have similar characteristics, those that they share experiences. There is also family support. Mr. Santi's wife and son are invited to join discussion about his care. They are educated on how to support him with meal planning and medication adherence. There's also coordinated continuous care before the start. Follow-up appointments are what scheduled with his primary care physician and wound specialist. So in the end, the hospital team communicates with its local clinic to ensure seamless continuity of care. What will be the outcome? Mr. Tati was empowered, yes, and respected in his care because in his care decisions. His treatment is personalized, yes, leading to better adherence and recovery. We don't involve any other person, but the team of health workers. Family involvement and emotional support improve his confidence in managing diabetes at home. Healthcare providers work as a team, ensuring coordinated care beyond hospitalization. So this approach is widely used in chronic disease management, maternity care, yes, palliative care, and rehabilitation centers to enhance patient satisfaction and health outcomes. Better patient outcome due to personalized care. Registered nurses is accountable for a wide range of services and functions at a higher level to ensure more consistent patient care. There's cost effectiveness is here. Workers are unit-based and spend more time in direct care activities. Disadvantage, it requires what? This significant time and yes, resource allocation to care for this patient. Could be challenging to implement in busy settings. Yes, but so we do it. We have the collaborative team and we take care of the patient. Nurse manager supervise many types of workers. Okay. There's also this one, differentiated practice model. Differentiated practice model. So with this model, we have those that are have the higher education and expertise in their fields. So the differentiated practice model is a framework in healthcare, particularly in nursing, that organizes staff roles based on their what? Their education. So listen, it's based on their education, their experiences, and competency level. So that is what we call differentiated differences. Differentiated practice model. And these are the people that have what? They're educated, higher education. They have gone ahead to do higher education. So it can start from the basic nursing care with the technical skills. We can have the degree nurses. Then we can even have the advanced master's. Yes. So this model ensures that the healthcare professionals are assigned tasks that align with their specific skills, optimizing care delivery, improving patient outcomes, and enhancing overall team. So that is where in some hospitals, we have our base degree nurses. When you go to school or when you specialize in this area, will not let you feel redundancy. We will place you at where you have your specialization, so that you don't a degree nurse, and I was the only person with the degree. So the director made, we were two. So he said, you are the degree nurses here in this hospital. We only have, we don't even have staff nurses. The few diploma nurses here, then all of them are that's it, it wasn't even the nurse assistant, but that old system. So he said, okay, now we have we made you in charge of training these people. So where we matter. And raising went ahead to do a master. So, oh, fine. So we put you in place where you can function very well, not even only on the ward doing the same process. That asset. You also have leadership and managerial position that you can manage so that you can function well. So every meeting, that's where he plays that in committees, and we organize some workshops and all those things for the nurses in there. So that is what we did. So the director did what? We didn't feel what isolated. So where our degree nurse, our masters, we were placed in some positions where we can train, we can educate, we organize workshops and all those things for the nurses. And we're even in charges. So that is what happened. So as I said, the purpose is to match nurses' roles with their education, with their experience, and their competencies to improve one's patient care and team efficiency. So the focus is what? Optimizing your skill, utilization, enhancing patient outcomes. So the model emphasis role clarity, encourage professional development. So when we were so young and we have finished our degree. So when we went to the hospital and the old nurses, you young people, we've been there and said, we have our degree and you don't even have a diploma, you don't even what? We were the old people. What would they call them for?
That could for nurses.
Health aides. Health aides.
No, the health aides. No Kufo nurses. Oh, this what will they call them?
Parents.
No, what?
They were pink.
They are the ward assistants.
No, not
Ward
ward
assistant.
Diploma or whatever. Oh, I'm really from there. So they were there. And even when they assisted, because there was shortage, then health assistant too. Oh, maybe I'll remember, then I'll let you. It's not for nurses. It's not health assistant. They were. Enroll nurses. Yes. The enroll nurses. Okay. Yes, the enroll nurses. You know, the enroll nurses somewhere. They didn't even have some diploma. They just had six months, whatever. Then they rose up to. Sometimes they even rose up to PNO, DNS, whatever. So it's just recent that we have a diploma. So when I went there, 2000. I said, no, you can't do that. You the beginners, no, you can't do that. Do you understand what I say? I say, we don't understand. So why is it vital? So please, we need to do the needful. So please, let's from hence now on, you will do the thing. You take vital signs and you chart it. And you know, they didn't even have the vital sign, the charts. So they wrote it in paper. So in a shift, instead of 6, 10, 12, 2 p.m., they only do it once. Then they will chart it too. So they call it chart free. They will not do the thing, but they will have some figures for you. I said, no, because you don't understand vital sign. That is what you are doing this. So the medical director said, you are the degree nurse. Why won't you develop some of these charts for them so that they will do it? So I started going around searching for vital signs. I said, from hence, this is what you're going to do. The time may have been taught that the 6 a.m. you're supposed to do the vital sign. Then also write. And even writing it, documenting it was a problem. Documentation was a problem. Where is the English that you're going to use to write it? So hence things started changing. And also our roles, because I was the first degree nurse then. And all of them were enrolled nurses, and few were staff nurses who have the diploma. And we had, as we said, the CODeL nurse also came. So we had to train the CODeL nurses to become nurse assistant. We gave them more certificates. And now some of them have gone ahead to do they are doing their masters. The CODeL nurses, yes, they had their diploma, do their BSc, and now some of them are doing their masters. They have done well. So this is how it's supposed to be. So that is also a model where we have higher people who have been there, so that they will not feel stranded. They are BSc nurses. What is their role in the nurse? It's not only about the practical area. Whatever managerial post or leadership thing that they are there, you can also let them know. Now we have a lot of a diploma, we have a lot of degree, and we have even master, even PhD people. But first, when we finished, we were only the first BSc nursing. So we are not many, but now we have a lot of them BSc, we have masters, even PhD. So as I said, the key components here is what education and experience levels. Nurses are categorized based on their qualification and clinical experiences, their competency and skills. Tasks assigned based on each nurse's skills and competency level. Then the role clarity, clear definition of roles for each level of nurse, example, RN, whatever. Then collaboration, it encourages teamwork and coordination among healthcare professionals. So that is the differentiated practice model. Differentiated. So we need to differentiate. This person is a diploma. This person has a degree. This person has a BA masters. This person has a PhD, and we all have our role, various roles to play in the hospital. So as you can see, there's optimal patient care. So we have our roles, specialized roles. There's efficiency. So there is quality. So efficiency, quality, expertise, and patient safety. So we can utilize the skills of each nurse level, whatever level that we have. We can utilize this and provide care, coordinated care to the patient. So the theory foundation of DPM is grounded in the concept of role differentiation. In nursing, this concept focuses on matching the right nurse with the right task based on their education, based on their clinical expertise, and based on their experience level. So nurses are expected to practice at a level that reflects their competency, education, and ensuring better quality care and reduce risk. So it is also draws on the concept of professional accountability as a profession. Professional accountability, where nurses are held responsible for providing care within their scope of practice. So when you want to implement this, you need to assess competencies. Regularly evaluate nurses' skills and qualifications. Clear role definitions, ensure each nurse's role is well defined. Continuous development, ongoing education and mentorship for staff advancement. So this is the DPM model scenario. So a large teaching hospital implement the differentiated practice model in its what? Medical surgical unit to improve patient care efficiency and staff. How do you apply this? It's a BSN, Bachelor of Science in Nursing. You take on leadership roles, you manage complex patient cases and coordinate care plans. You can also lead leadership works, discharge planning and patient education, and even staff education. Then associate degree nurse or diploma nurses focus on bedside, yes, including monitoring vital signs, whatever. They work under the words supervision of what? The bachelor degree. So the BSN nurses for complex patient needs. And the LPNs assist with basic nursing. We don't have a task such as FIDA, but we have the staff nurse and all those things. Then we have the certified nurses, provide fundamental support, including bathing, whatever, to the patient. There is what? Efficient patient care and teamwork. BSN, who assesses the condition, collaborates with physicians and develop care plan. You can also assume leadership roles, what in charges and all those things, workshop and all those things. The next ADN, who administer medication, LPN, CNO ensures this. Then there's improved patient outcome. Nurses work within their competency levels, ensuring high quality, efficient care. The model helps reduce errors, enhances patient satisfaction, and optimize resource utilization. So there's cost effective and scalability. The hospital reduces costs by allocating tasks appropriately, avoiding unnecessary overuse of highly trained RNs for basic tasks. Yes. It encourages career growth as LPNs and ADN nurses are supported in advancing their education. What will be the outcome? There's efficient workload distributions, and this enhances patient care. Nurses work at the top of their licenses. The degree, the diploma, we recognize you as a diploma holder, degree holder, master's holder, or doctorate. Better teamwork and collaboration, improve overall hospital performance. So this model is commonly used in teaching hospitals, yes. Teaching hospitals, specialty units, and healthcare organizations that aim to balance cost efficiency and quality of care. So this is the differentiated practice model care and contribute to patient safety, allow for the most effective and efficient use of scarce resources, increase satisfaction for nurses, provide opportunity to compensate nurses fairly based on their expertise, their contributions, and productivity. But here, obviously there's a discrimination here, but you can't do anything about it. So that's why it also encourages you to also move ahead, develop yourself. So there is a discrimination between licensed and unlicensed personnel. Yes, and in this case, a lot of people have moved on, developed themselves, yes, because of this discrimination. Identifying the required or competent nurse might be difficult. It's in several cases, difficult in several cases. Givers are involved with care rather than just one person. The results in task-oriented versus total patient care approach, which may include fragmented cares. So these are some of the factors that can influence the choice of the model, as I said, to use. You need to assess patient acuity and complexity, the staff availability and the skills the mix. Then the institutional policy, budget constraints, and patient preferences. So this is sometimes when you want to implement these models, you also need to consider these factors before you implement this model. But now we have also emerging trends in care delivery. We have the technology integration. That is where we have electronic health records, interdisciplinary team approaches, value-based care models. These are some of the things that are also coming. Then patient empowerment and shared decision making. So what will be the impact on patient outcomes and nurse satisfaction? There's improved quality of care through better nurse-patient relationship. It depends on the type of model. In every type of model that you use, there's advantages there. There's efficiency in resource utilization and reduces workload strain, enhanced job satisfaction in models like the primary nurse, yes. Then potential risk in fragmented care like the functional nursing, yes. How do we evaluate the nursing care delivery system? So when you are evaluating these models, you need to ask yourself the following questions. And if you're able to answer them, then you can. Are patient outcome being achieved in the timely, cost-effective, a particular model that you are using? If it's okay, then you can go ahead and do it. If it's not okay, you can change the model and use the one that can suit the system. Are patient and family satisfied with the care with that kind of model that you are using? Are physicians and other health members satisfied with the care? Does the system allow for implementation of the nursing process? So whatever system whatever model that you are using, would you allow you to use the nursing process approach? That the system facilitates communication among all members of the health team. So if you're able to answer all this correctly, then it means the particular system that you are using are good. But if no, then you need to change your strategy. So nursing care delivery models impact patient care quality. Choosing the appropriate model enhances what efficiency and patient satisfaction. Flexibility and adaptation towards healthcare changes are vital. So in our system, no single model is universally superior. It depends on the situation. So effectiveness depends on the setting and the resource that we have. Then it will help tell us which kind of model. And even the situation at one time, then will also let us know which type of model that we can use. Now we are using it, but without knowing that we are using this particular model. Even the patient education that we do, diabetes clinic and all those things. We have the patient centered care. But we are using it that we don't know that we are using it. But when we are using now even care nursing have adopted the family whatever system. Yes. The family model care. They have also adopted this. We have to go and look at this model. Next time I need to add it here. They have added that one. Family model care. So when you go there, they ask you which of the model of the care that you want. So as I said, no single model is universally superior. Effectiveness depends on what setting and resources. But in the trends and innovation in nursing care delivery, there's technology integration, there's AI patient monitoring, telehealth care, there's interdisciplinary collaboration, shared decision-making models. We can also have the flexible care models, that is a hybrid. Hybrid approaches blending different kind of models. We do it there without knowing that we are blending it, we are using hybrid. There's value-based care, focus on outcomes rather than service or volume. So these are some of the trends and innovation in nursing care. Then family practice model. There's also family practice model that is also coming up. There is a new model. and some hospital has also adopted it. I don't know if the outcome will be good. By you, let's discuss which model do you think best suits Ghanaian healthcare settings? Which model? So which model do you think best suits Ghanaian healthcare settings? Wherever you are working, which model do you think will suit your care setting? Let's discuss. Hello.
Hi.
Wherever you are working. Yes. Which model?
Team nursing.
Where are you working? And have you assessed the place that you see team nursing is better?
Sure.
So how can we improve patient-centered care in resource-limited settings? So how do staffing challenges influence the choice of a care model? So these are all the things that we are going to discuss. So here, it's a scenario here. Miss Amma, a 55-year-old woman with type 2 diabetes and hypertension was admitted to the hospital due to uncontrolled sugar levels and high blood pressure. She had a history of non-compliance with medication and lifestyle modification. So this is your assignment. I will need it. When do I will give it to you. Then I'll give you the time space. But still, you need for this, you will also have to do your presentation. But this is your takeaway assignment. And I will take them. I'll send it to you. Okay. On nursing care delivery model. So assignment will be given and presentation will also be given. So next week, God willing, I think we will discuss. Okay, it will bring yourself. Okay, so I have a lecture. If you don't have any contribution, we end here. And did I give you last lecture notes? Did I send you? Have I sent you the lecture notes? Let me hear from you so that I can add this one to it. Hello? Hello?
Yes, please.
Hi. No, please.
So which one? The last one was it one management or what?
Yes.
Yes,
So
please.
the left is one management and this one. Okay, because this one contains an assignment. I need to give it to you so that you do the assignment as well.
Sister, please, the other one was the quality management.
Hey, thank you. I've given you the word management. Why?
Yes, please.
So it's
Yes,
left with
sir, you've given us that one.
so left with the quality and this one.
Quality
And this one,
assurance.
yes, quality management. So it's quality management, but quality assurance is a component of quality, whatever.
Okay.
So I'll give you this one, and as there is assignment in here, then you have to do the assignment and submit. Okay, so I'll see you.